and they will be sharing their ground experience for dozens of patients who are being put on Immunocin alpha, that is Thymosin alpha. So I welcome Dr. Vimal Ranka from Ahmedabad and Dr. Chinmay Godbole from Mumbai. After our case study presentations, we will be going for panel discussion and question answer session, where Samrat has already talked regarding the pattern of questions. So you please put in this chat box so that the questions can be picked up. So for our panel discussions, today we have all our three speakers, Dr. Om Shivastov, Dr. Vimal Ranka, Dr. Chinmay Godbole, along with Dr. Adarsh Shetty will be there, who is the medical advisor of Gufic Bioscience Limited. Dr. Navneet Wadhwa will be there, who will be the coordinator for the panel discussion. And Dr. Rahul Bahat will be there as our panelist. This is the flow of the program. Now today, in fact, before I narrate you or I tell you regarding the topic of the webinar, I'd like to give you a small brief regarding our honorable speakers. Dr. Om Shivastov, who is our speaker today, is a well-known personality, not only in India, but in international forum also. Dr. Om is the consultant and HOD for infectious disease, immunology, and HIV medicine for Jaslok Hospital, Mumbai, Saifi Hospital, Mumbai, Oakard Hospital, Mumbai, HN Reliance Hospital, Mumbai, and Kasturba Hospital, Mumbai. Dr. Om is also associated with D.Y. Patil Medical College Hospital as a professor and HOD, which is situated in Navi Mumbai, that is New Mumbai. As you know, doctor is having different credentials for national as well as international publications and forums. Welcome to you, sir. Today we have the case presentation from two of the eminent doctors from, one is from Bombay and another is from Ahmedabad. So I welcome Dr. Vimal Ranka, who is the critical care specialist for Gujarat Research and Medical Institute, GRMI, that is in Ahmedabad. And he is the head of COVID-19 cell in the hospital also. Dr. Chinmay Godbole, who is consultant intensivist for KJ Ramaiah Medical College and Hospital, Mumbai. So I welcome on behalf of Gufic both of you, sir. Our panelist, already I have explained to you, Dr. Adarsh Shetty is an MD from BHU, Banaras Hindu University. Dr. Navneet Wadhwa, he is also MD from Manipal, and Dr. Rahul Bahat, who is consultant chest physician from Jaslok Hospital, Mumbai. Today, our topic for discussion and for the speaker which he will be taking is role of Thymosin alpha 1 on T cell, the unsung warriors, in various stages of COVID-19. Now, COVID-19 is one of the trauma which we are facing last 5-6 months across the globe. Almost 3 crore people are being affected, in which around 50 lakh is from India. And if you see, in our last discussion, when we were talking regarding the need of the molecule Thymosin alpha, the perfect immunomodulator, that time we had 30 lakhs of patients, and today we are touching almost 50 lakhs. So in these 2-3 weeks, the patient is doubled almost. And every day it is increasing at the rate of almost 1 lakh patients. We do not have much more drugs to tackle COVID-19. Still, with the use of many drugs, whether it is a remdesivir, whether it is a different type of drugs, antibiotics, injectable antibiotics, doxycycline, we go for LMWH, and we are tackling this disease. The vaccines are not already been in the market. No, we do not know when it will come. So there is a need of some of the drugs which at least augment your effort. And that is why thymosin alpha has been involved. This molecule was been approved by DCGI and US FDA for different indication around 40 years back. So 40 years, there is a safety data and there is a legacy data, but it was never been tried because COVID-19 was not there. So we have a lot of publications and trials recently which has evolved on COVID-19. And I am very, very, very happy to tell you that DCGI has given us the approval for phase 2 trial for thymosin alpha, that is Immunocin alpha, and the process has started in 6 centers. Before that, we have already started investigator-initiated trial in 3 centers, Mulund Fortis, Kasturba, Mumbai, and Nanavati. And today, we have around 600 patients experience with 400 doctors across the country in last couple of weeks who are being used with thymosin alpha, that is Immunocin alpha. With this background, I wanted to hand over the session to Samrat so that Samrat hand over to Dr. Om Shivastov. So thank you very much, and please attend this webinar with full concentration, followed by our case studies and also panel discussion. This is the second webinar in a series. Our third webinar will be there in the mid of October, where we will be talking more on inflammation versus infection and the role of thymosin alpha, Immunocin alpha. So thank you very much, Doctor, and over to Samrat. Samrat, please.
Thank you, sir. With this, Doctor, I'm welcoming Dr. Om Shivastov to please start his presentation and his speech. Over to Dr. Om Shivastov.
Can you hear me? I have unmuted myself, but I can't see myself on my slides on screen.
Yeah, sir, you are very much audible and your slide has just been shared.
I can't see them on my screen. So if that is the case, somebody will have to change the slides unless I can't see my own slides on screen.
So it is visible to us, sir. Is it visible now, sir?
No, I can't see. I can hear you, Dr. Samrat, but I can't see. I can't see the slides on my screen.
Dinah, would you please stop the sharing and again do the restart of the sharing? Now it is visible, sir.
As soon as I can see that, I will let you know. But I can't see either of them, either of this part of the screen.
Okay. Now is it visible, sir? We have against reshared again.
There is nothing on my screen. Should I be exiting and restarting myself?
Dinah, I think so. You stop the sharing. Let me try out if I can share and if sir can see. Dinah.
Yes.
I'll have to call you back.
Om sir, can you now see the presentation?
No, it's not yet visible. Okay. All right, I can see the slides now.
Okay, sir. Thank you.
All right, so Samrat, I'm starting now. Good
Yes.
evening, Dr. Devesh Das. Good evening, everybody else. I think since we've already lost a good about 5-6 minutes here, I'm going to try and stick to time and finish up my part of the talk at least, so that everybody else has enough time to finish theirs, and we have enough time to go through the questions. So, first of all, thank you, Dr. Devesh Das, for the opportunity. Thank you, Gofik, as well.
Thank you, sir.
I should thank both Dr. Navneet Wadhwa and Dr. Rahul Bahot, who have been critical in helping me, get these slides done for this evening's talk. Very generous introduction, Devesh. I don't think I deserve all of it. I've always maintained that when a speaker needs more than one breath to talk about himself, the rest of it is about his ego. Yes. So I'm going to be again acknowledging Dr. Devesh Das for saying all that he did. I'm not sure if I deserve it, but let us get started. Thymosin alpha then. Thymosin alpha and its impact on T cells at various stages. Why is any stage important? It is crucial, as we have seen here. It is crucial why you need to understand the immunology of COVID, not just of COVID, but also what thymosin can do. So I'm going to get started from here. Okay, it turns out that now I am not able to change my slides. Okay, Samrat, can I request somebody to just change the slides? Can I give you the cue, if that's okay?
Yeah, sir, I've already changed the slide.
Okay, fine. So this is the first slide. We'll keep going. Please go to the next slide. It's okay. He's changing it. Okay. I think this is something that Navneet was keen to incorporate. Again, I have to thank him for all his generosity. These are some of the papers that I have published, some of the studies that I have taken part in. So when you say, sorry, just 1 minute, I'll quickly go through this part. Eosinophilic gastroenteritis in somebody who was seropositive with HIV. Why is that important? Very important, where T cells were responsible for the chronic diarrhea. This man had a diarrhea who lost about 34 kilos in a year's time. And then once the diagnosis was made, it took him about 6 months or 7 months to get back all his weight. And the other one that you can see on the right-hand side on your slide is the hyperkalemic periodic paralysis that led to a Fanconi syndrome that is also mediated through the patient's T cell. Paniculitis, mesenteric paniculitis, which was the first that was reported in bariatric surgery. Also crucial to that part of the disease is the patient's T cell. So a number of the publications that I have made are about T cell dysfunction, and I will say a few quick words. Next slide, please. So memory CD4 cells and CD8 cells, both which are induced by SARS in convalescent individuals following COVID-19. That is so important. That is so important that specific T cells are protective. And we are now looking at T cells and their memory in the whole course of the disease. So T cells are probably going to dominate. Of course, it's too early right now, but they're probably going to dominate our understanding of COVID, and not just COVID. Let me share with you something that is my own philosophy here. COVID is going to be the cause for a number of diseases, including autoimmune diseases, including chronic disorders, including things like prolonged encephalopathy or myelopathy or myopathy. And in all of these situations, you're going to look at the need of an immunomodulator. So we are still in the process of learning and understanding about the immunomodulator, which is thymosin alpha, and that we will need to wait and see what the trial shows up. But it is the process where you will need to validate how good a molecule is, and we're looking at doing that. So I think that when we finish with the trial and we meet again, we will know exactly what good does thymosin do in in working as a immunomodulatory agent, specifically in COVID, but I have a feeling it's going to be relevant and important in a number of other conditions, including autoimmune diseases. Next slide, please. Okay, then T cell responses. I'm not going to go into a lot of theory, but each bar, if you have a look at the right side, each bar shows responses of each individual to all of the SARS-CoV peptides that were responsible. So I think this is a wonderful slide, but in the best interest of time, I'm going to spend only one more minute in talking about this, that there is convalescent patients who are infected with SARS will show variable T cell responses, especially with memory T cells, with CD4 cells that we are measuring in a number of institutes that I am practicing, where I am practicing, and that the results that are coming out are terrific. But I'd like to see even more, that once we know that thymosin alpha is going to be safe, we will need to be looking at what is going to be the response with its safety in this kind of condition. So I'm sure we're heading in that direction. When I keep just saying that, because we are people who are so obsessed with evidence-based medicine, as we should be, just so that molecules that we use are safe. Because we are so obsessed with safety, I would like to see what the trial results are before we can actually say that this is what we are looking at. Next slide, please. Okay. Essential to understand what is it that we need to inform therapeutic interventions. All right. So specific T cells, which are broader and stronger, and that I say again that if we find that there is good evidence about thymosin alpha, I'm going to request Dr. Debish Das to fund any further number of studies. So I hope that Devish is listening to this and he's ready
Yes,
for
sir. Yes,
funding.
sir.
Yes,
Yes, sir.
he's ready for funding another a dozen studies that we can take to the international level. All right. So
Yes, sir.
I,
Yes, sir.
I think we're heading in that direction.
Yes,
There
sir.
is also, as the slide says, which is direct virus-induced pathology with inoculums, and there is poor innate immunity. Understanding the roles of different subsets of T cells in protection and pathogenesis is crucial for the prevention and treatment of COVID. So, look, we are already in the process of saying somebody who is young, 26, 24, 20, 18 years old, who had COVID, is now showing severe damage to their lungs post-COVID, 2 months, 3 months after COVID, because we could not use anything like an immunomodulator. I think that the role for thymosin alpha is going to be more and more well established in those situations, and that we will probably find that the role of something like thymosin alpha is going to be around for a number of years. Number of years. I don't mean months. I mean a number of years, because the damage of COVID is going to be so prolonged. I think that by the time we come to this time next year, there are going to be certificate course in COVID, to a 3 month course in COVID, to a DNB in COVID, to a DM in COVID. Yeah, that's how important COVID is going to be in our understanding of disease. So I think we need to be ready of not just the long-term haul of COVID in our lives, but also in getting COVID to be the center point of uh, of what we are going to be using as treatment. Next slide, please. Okay, again, in diversity, is there unity? Well, it certainly looks that way. T cells are united in a very comprehensive fashion. And if you map them, if you look at the left hand side, it's a look at on this slide, I can probably keep speaking for about 3 or 4 hours, but don't we have that kind of time? I have to say, only because of my own passion for immunology, I could speak about the Dr. Devesh Das. My request is we can have one webinar on this one slide alone. All right. So
Yes, sir.
I,
Yes,
I
sir.
would love to speak about this for more time, but there is definitely unity in diversity, and that because of this unity, the total amount of responses of the T cell in COVID can become either very good or very bad, depending upon what stage your patient. And that's why, see, I often say this. Why is it that COVID affects one person in the same profile? 45-year-old man who is a non-diabetic, non-hypertensive, is not obese, is not a tobacco chewer, not a smoker, not an alcohol consumer. One person recovers very well from COVID, another person succumbs to COVID. Okay, we've just had a very popular man from the IES lobby that was fined 5 days ago and succumbed yesterday. Less than 4 days is the time that he took at a hospital, at a major hospital in Lucknow. Succumbed in 4 days' time. He was talking 2 days before he succumbed, went on the ventilator and succumbed. So immunity is something which is not a broad blanket for everybody. It functions differently, it responds differently in different people. There are triggers for the COVID storm, the cytokine storm, and there are those triggers which will not behave badly in a different situation. So it's not that every person is going to respond in the same way, and that is why we need to look at not just the immune system but also immunomodulators. Right now, the only molecule that I would like to see what the results are, I keep saying again and again, not because this is a session sponsored by Gufic, but because thymosin is something that I am very keenly interested in following as to what the outcomes are. So important slide, but not the best time to talk about it. Next slide, please. Again, in diversity, so like I've been saying, some individuals may have a head start in the race against the virus, some don't. And T cell memory at any given time is something that will determine how the disease progresses, from one point to another. Recent T cell support use of vaccine, but vaccine modalities is still, this is now September of 2020. I don't think we should be prepared for a vaccine before end of 2021 or even 2022. Vaccines will be there. They'll probably help, but they will go through. This is still the first generation. They'll probably go through the fifth, sixth, seventh, eighth generation, 10th generation before they become a reality. So I wouldn't wait for it right now, but I'm sure that it's going to be important at some stage in the future. Next slide, please. Okay, again, since its emergence, COVID has shown two overlapping phases. If you can see the slides again, I'm not going to go into too much of theory, but with the SARS-CoV virus, there are those aspects of the immune response where you are going to get either a cytokine storm or you're going to get a tolerance. This is the point I was making a little while ago, that there are some people who will become tolerant because their own immune system is able to understand, appreciate, and negate, put these triggers under control, under wraps, literally put them under lock and key. There are those whose immune system is not recognizing this immune storm, and that because they don't recognize, the immune systems don't recognize, it will go into a state where there is going to be a hyperimmune kind of syndrome. This is similar to the papers that I have published earlier. This person who had about 34 kilos of weight loss in a year's time had a hyperstimulatory immune response. But once we knew that this is what is causing him this problem, once we were able to treat both the underlying issue and the current problem, this man regained all his weight in a much smaller period of time. So immune systems can be trained, they can be taught how to behave, but for that, there are two things. One is that the clinician must understand immunology, Two is that he must know what he wants to do. Next slide, please. Somebody please tell me when I'm overlapping on my time and it is time for me to stop. Please, please either message me on the chat box or simply say it here. Okay.
Sir, please
So
continue, sir.
yeah, all right. Hallmarks of COVID and associated biomarkers. Yeah, it's pretty explanatory. What you are going to get with the innate immunity, what you're going to get with the acquired immunity, adaptive immunity. There are going to be those parts which I have already mentioned. The hallmark of the innate immunity is going to be, one part of them is going to be the cytostorm and over-inflammatory response. The adaptive and the phenotypic response is going to be different to that, where you are going to get from neutrophils to natural killer cells to D-dimers, all those things that we measure. We are looking at the importance of the presentation of both the innate and the adaptive immunity. So it's actually the basics of immune physiology when we are talking about these slides. But it's important to understand in the perspective, because you may say, okay, this patient has got, say a neutrophilia. Okay, so is that expected? Well, not sure, but it's an infection. There may be neutrophilia. But when you've got a lymphocytopenia, is that something which is easily explainable? Well, the answer is no, because I've had patients where the lymphocyte count in the middle of COVID was zero lymphocyte count, and some patients, just about 25, maybe 30 patients, I've had zero lymphocyte counts for over 2 weeks time. Now, is that natural? Is that physiological? Well, there's no such thing as zero lymphocytes physiologically, because we can't just measure the lymphocytes. Yeah, it can't be zero lymphocytes, because with that the patient is probably going to get devastating infections and die in a period of 5, 6, 7, 8, 10 days time. So there's a great deal that we don't understand, and that in this lack of understanding, we need to be working harder in trying to get to the bottom of a process of which we know maybe 5, maybe 10%, not more than that. And so that is why, again, we may not understand the entire process, but once we have scientifically proven that it is safe, then there is a role for something like thymosin alpha in all of these conditions. Next slide, please. Next slide, please. Okay, so immune responses in COVID-19, what kind of immune responses are you looking at? How many hours, how many days, how many weeks, all right? Everything should be settled by the time your patient gets to 14th, 15th day, all right? Maybe close to 20th day, not more than that, not more than that. But sometimes we'll find that the immune response may last for much longer. Why is it that some patients who are otherwise without any risk factor, fit and healthy, why is it that some patients, after they've recovered from COVID in 15 days time, come back in about 3 or 4 weeks time and say that, look, my there is a little bit of swelling in my legs, and you do an ultrasound, you find that there is clots in both the legs, and not just small clots going from the deep veins going right up to the patient's the thigh region, right up until the iliac vessels. It's getting commoner and commoner. And so why does that happen? Is that the immune response that is misbehaving? Well, most likely it is. But why is it misbehaving? We don't know. We're looking into that. We're trying to understand that, but we can't say emphatically that this is the reason why this happens exactly. We are still working on it. We are looking at literature every day, especially individually and people in the task force. We look at this literature on a daily basis, and we share notes amongst ourselves as to why is it that this kind of thing is happening. So a lot of things that are in evolution, the time course for the proposed immune response is what appears to be reasonably accurate on your screen right now, but it is a changing dynamic, and we are still trying to understand why this goes on for longer in some patients. Next slide, please. Okay, a mirror image of sepsis. Yes, it is immune responses in COVID. It's quite similar. It's quite similar, except that in sepsis, you'll probably find that the bigger problem is that you're dealing with something like, in prolonged sepsis, the T cell exhaustion is probably identical in numbers, but it may not be almost always identical in the kind of responses, because T cell responses in sepsis, again, this is a topic for a separate webinar altogether. When you say I'm going to give a patient who is septic an antibiotic for 3 to 5 days in ICU, right? You stop that You stop the antibiotic, but your patient's T cell population is still recovering and it's going to take 3 weeks to recover. Is that, are you doing your patient the best service that you can, or are you leaving him exposed or her exposed to more infectious disease complications? So when you say that, oh, look, this patient started with a bacterial gram-negative sepsis and then went on to having another viral infection, or the fever is not getting down, or there is this new fungal infection, what is that happening? You say, oh, look, it's nosocomial, it's hospital acquired. Except that, are you sure it's hospital acquired? Have you measured the patient's T cells? If you've not measured the patient's T cells, then you're actually fooling yourself. You're actually kidding yourself that it's hospital acquired. You need to be looking at that more carefully. And that is where the role of T cell comes in. So T cells and immunology in the understanding of sepsis, of course, COVID as well, but also sepsis, you need to be able to understand that which T cell is going to be behaving in what way. Next slide, please. Next slide, please. Okay, so again, this is uh, this is an important slide, but I'll only share with you, the basics of the slide, which is, host defense responses, host directed therapies against the most relevant of pathological hallmarks of COVID. So there are a few therapies that we are using with good effect, but what I think is going to be the most important is what is highlighted in the yellow box, in the box, not the yellow box, in the box on your screen, which is going to be thymosin alpha. So again, I will say it again, the evidence that we are seeking is still not in our hands, but I am looking forward to it very hopefully that it should meet the requirements that we have in our mind. Next slide, please. Okay, so how is thymosin alpha going to help overcome these changes? This is a busy slide, but trust me, it's an important one, because it simply tells you that these changes that we talk about in immune responses which are dysfunctional, they function at multiple levels, all right? Not just at the level of the T cell, but also the B cell, the natural killer cell, the complement studies, the immunoglobulins, the TNF alphas, everything, all of these molecules that I have just mentioned come into play, all of them. And that there are other pathways that we are not going to be able to speak about here tonight, this evening. But there are other pathways where, you know, things like very basic ones that we probably read in our physiology years or pathology years, the arachidonic acid pathways, the role of leukotrienes, especially the leukotrienes, LTD4s, all of those come into play, because when I say all of these come into play, because these pathways are going to be the reason why your patients are going to get clots or bleeds. And that when we say that some patients need to be on prolonged aspirin or prolonged clopidogrel or prolonged clexane, even after they've gone home, we talk about inhibiting these pathways. So there are a number of pathways that we don't know a great deal about, but we know that yes, if you are getting a clot, 2 months after you have recovered from COVID in a young, fit, healthy male, then there is definitely a pathway which is uncovered, unprotected, and you should be looking at protecting that pathway. And that's why we use an antiplatelet or an antithrombolytic agent for a prolonged period of time. Next slide, please. Okay, Thymosin alpha and the scientific journey. That's actually a very, very interesting process. Very interesting journey. Thymosin alpha restores the binding of autologous erythrocytes by T cells from cancer patients. We know that. That's very well documented and studied. Thymosin alpha reduces the mortality of severe COVID by restoration of lymphopenia and reversion of exhausted T cells. Remember again, having a T cell that is numerically normal or slightly low, but having this T cell which is completely exhausted is two different things. An exhausted T cell, which is by numbers okay, is going to be the biggest problem, because that is misleading. You may think that your patient's T cells are fine because the numbers are okay, but if they are exhausted, then your patient is still left at a huge risk. So again, a large part of immunology is not just understanding and limiting yourself to numbers. It's about being able to say that in the overall picture, this is what the number means, right? Next slide, please. Okay, as I have mentioned earlier, not today, but earlier as well, active hepatitis B, stage 2, stage 2B to stage 4 of melanoma, hepatocellular carcinoma, and the D. George anomaly, which is an immune defect. All of these have responded beautifully to thymosin alpha. That is why there's a great deal of hope as to what can be done with COVID. And of course, I like I've said this earlier, I think that there is going to be a role for even autoimmune diseases for thymosin alpha. We'd like to wait and see as to what else can be done besides COVID by thymosin alpha. We can decide from there as to where it is heading. Next slide, please. Okay, reduces mortality. I've already spoken about this. Next slide, please. COVID patient mortality. Again, this is some part of these are repetitions. I will just talk about the one trial that is here, which is 36 patients in a 40 patient non-treatment group. What happened with the T lymphocyte count? What happened with all the parts of the T and the B lymphocyte counts? And what happened with the PCO2 and PCO2, especially on admission and on discharged? Patients recovered with with both these conditions. Next slide, please. Okay, restoration of lymphopenia, reversion of exhausted T cells. These are the two major findings, and we are hoping that this is going to be replicated in the trials that we are doing in India, and we'll know that very soon. But this is where we are, and that's what we are hoping that this will do. Next slide, please. Yeah, mortality is reduced by thymosin alpha. Okay, next slide, please. Okay, this is a little bit of theory. I'm not going to keep going into this. Next slide, please. Yeah, same. It's the same conclusion that I have drawn earlier. So we'll keep going. Next slide, please. Okay, again, this is going to be making the same points that I have made earlier. Next slide, please. Yeah, all right, let's keep going. Next slide, please. All right, so finally, there are 3 C's, which is part of the carry home messages: capacity to improve and restore T cells, can reverse T cell exhaustion and induce innate immune thymus production in response to COVID-19, and collectively contribute to the reduction of mortality. Next slide. Okay, so I'm actually going to take a break here. I'm going to stop here. I'd like to say again, we must have open minds for those molecules that may be able to open other avenues besides simply giving a single antiviral agent. It's not only the virus and the antiviral agent that we are worried about. It is the underlying immune system response of patients that we are concerned about. And we need to have something which is a broader sword to be able to combat those things. And that is why, because this is something which is an immunomodulatory agent, I have my keen interest in following thymosin alpha. I hope it meets all the promises that it has made up until this point, because definitely COVID needs something that will be important to correct the immune dysfunctions. And I hope that it meets its expectations. Yes. So I'm going to again thank everybody for a very patient hearing, and I will wait for the other speakers to finish before we take the questions. Thank you.
Thank you, Dr. Om Shivastov, for the presentation. Okay, with this, I will be requesting Dr. Bimal Ranka to please share his presentation on the case studies, live case studies on COVID-19. Over to Dr. Bimal Ranka.
Hi. Good evening, everyone. चालू है? दिख रहा है? Hello? Am I visible?
Yes, sir, your presentation is visible.
Okay. Okay. Hi, everyone. Good evening to everyone who has been attending this webinar. And thanks, Dr. Debesh Das, for giving me this opportunity to present my findings in the form of this COVID case studies.
Thank you, sir.
So, yeah. I've been working, I'm Dr. Vimal Ranka, and I've been working at GRMI as a critical care specialist in Ahmedabad and working as in the COVID department from last almost 4 to 5 months. And initially, we've seen when we had nothing at hand, we just used to treat patients with steroids and heparin, and then slowly we got hold of a lot of new molecules like tocilizumab and remdesivir, and now we have the immunomodulators, that is the thymosin alpha. We Thymosin alpha for almost a month, and we have used in almost more than 50 to 100, more than 100, and we've got excellent results with that. These are the few case studies that I have, and I'll just share it with you. This is case one, and we had a 62-year-old male patient who presented in the emergency department. He had fevers in 7 days, loss of appetites in 7 days, sore, and when he presented, he was severely tachypneic, and he had a history of breathlessness in his last 2 days, but he was at home and quarantined at home, and he was taking treatment at home. Now, this patient was a known case of diabetes type 2 on OHA, hypertensive 1 medications, and had morbid obesity, and he was taking treatment for the same. Now, when he presented in the ER, he was febrile with a temperature of 101 degree Fahrenheit. He was severe tachypneic with respiratory rate of 40 per minute. His pulse was around 120 per minute. Vitals, blood pressure was normal 140/70, but his saturation was 85 on room air. So we shifted him to the intensive care unit, and before we shifted him, we got an HRCT done, which is a normal protocol. Whoever patient presents directly to the ER, since it's a COVID pandemic, we got an HRCT, and which was classically suspicious of COVID. These was his HRCT, if you can see, ground glass opacities bilateral. So patient was immediately shifted to the intensive care unit. We put him on BiPAP because he was very tachypneic. Initially, we started him with 70, 50, 60% FiO2, but he could not maintain his saturation. So we had to put him on 100% FiO2 with PEEP of 10. And with that, he maintained a saturation of around 91, 92. All routine investigations, the COVID profile, that the inflammatory markers and everything was sent as per the COVID protocol. And we did send the COVID RT-PCR, which turned out to be positive the next day. This was his CT findings. Classical ground glass opacities, you can see bilateral. Now, patient was on BiPAP support with FiO2 100%, PEEP 10, and he was maintaining a saturation of 92. Patient started on IV antibiotics, steroids, low molecular weight heparin, and supportive medications. After we got his COVID RT-PCR report, we started him on thymosin alpha on day 2, and we gave him at a dose of 1.6 milligram, that is 2 vials subcutaneous BD twice daily. So this is his sequence, the way he was followed up. Initially, he was on a BiPAP with a FiO2 support of 100% with PEEP 10 and on methylprednisolone on low molecular weight heparin and supporting medication. The next day, we started him on Immunocin alpha, that is thymosin alpha, and we just since we had given him steroids and everything, we reduced the FiO2 support by 10% with a PEEP of 8. He was maintaining saturation of 94 to 95%. We followed up on this BiPAP support. Slowly, we reduced the BiPAP support to 60% and then to almost 5 of PEEP, and he was maintaining a saturation of 96 to 97%. On the fourth day also, we continued with the same thymosin alpha, steroids, antibiotics, low molecular weight heparin, and patient tachypnea reduced, and planned putting him on oxygen mask, 10 liters oxygen mask. So the next day, patient was maintaining on 10 liters oxygen mask, a saturation of around 95, 96, with a respiratory rate of around 22, 24. We switched on to low antibiotics, put him on reduced oxygen requirement to almost 4 liters, and almost in a span of around 6 days, patient came down to a saturation of 90, made his saturation of 92, 97% with 2 liters oxygen, and we could shift him to room on just 6th or 7th day. On 8th day, patient came on room air, maintaining a saturation of 98%, and on the 10th day, we planned for discharge. Now, during his whole hospitalization, this was a markers that we got done and how the patient followed up. When he presented, he had lymphopenia, lymphocytopenia. His CRP was very much elevated. D-dimers was in the range of 14-20. His IL-6 was 170. Ferritin markers were elevated. And on the second day, we got CRP came down to 240. The next day, we got his again WBC count done and differential done. Lymphocytopenia a bit marginally improved, and his FiO2 requirement came down. Ferritin also marginally came down. And on the sixth day, the lymphocytopenia improved. His WBC counts almost to 9,420, maintained a saturation of 97% with 2 liters. So we gave him thymosin alpha for almost 5 days. And this patient was very important because this case actually we did not, it was very tachypnic, and somehow we could not manage to give him remdesivir and tosi, and we just gave him thymosin alpha and steroids and low molecular heparin, and patient wonderfully improved within 7 days, who was initially on a BiPAP with an FiO2 of 100%. Within 7 to 8 days, we could be and get him on room air. This is the second. This was now the second case. This was now a 74-year-old female who presented in the ER department. Fever since 5 days, generalized weakness. She presented with severe diarrhea. She had dry cough and she was breathless, tachypnic when on presentation. Now she had a significant medical history. She was diabetic since 10 years on insulin and OHA. She has a case of IHD on dual antiplatelets, asthmatic on inhaler therapy, and she was basically home quarantined for almost 5 days. She was taking treatment from a family physician, and she was almost home quarantined. And she presented to us in the ER when she was very much breathless. Now in the ER, she had a temperature of 102 degrees Fahrenheit, pulse 120. The respiratory rate was around 38 per minute, and she was maintaining a saturation of 78% on room air. See this scattered area of bilateral ground glass opacities. The CT was quite bad. So on 11 August, we admitted symptoms of cough, fever, generalized weakness, saturation of 78%, heart rate of 124 per minute. HRCT bilateral ground glass opacity, we shifted to the COVID ICU. All the COVID profile was sent, and we started on our HFNC 40 liters with FiO2 of 18. The next day, COVID RT-PCR turned out to be positive, so we started on IV methylprednisolone, remdesivir, low molecular heparin, and thymosin alpha 2 vials subcutaneous twice daily. Patient was maintaining a saturation of 92 to 94% on HFNC 40 liters with FiO2 of 80%, but was still febrile. We continued with the same treatment. However, on the 5th day, patient became afebrile. We continued with remdesivir, continued steroids and low molecular heparin. We tapered off the steroids, and somehow the requirement decreased to almost 10 liters NRBM. We continued with injection remdesivir and thymosin alpha till the 7 days, and oxygen requirement decreased from 10 liters to 6 liters and into almost 4 liters. On 8th day, patient requirement came down to 1 liter. Patient had no fever, decreased. So we stopped thymosin alpha, continued with remdesivir for another almost 10 days. There was no coughing. Patient saturation was room. Now this was his investigation chart. On admission, he had a WBC count of 440. Severe lymphocytopenia, CRP was elevated. D-dimer was in the range of more than 10,000. Ferritin was more than 2,000. Initially was on HFNC with 40 liters. On the third day, D-dimer again more than 10,000. Lymphocytopenia probably to somehow improved. CRP came down a bit marginally, and on the sixth day, lymphocytopenia improved, counts were almost near to normal, and patient came down from HFNC to 15 liters NRBM. And almost on the day, his ISC was less than 2, and on the 8th day, his CRP came down to 6.6, D-dimer was 191, patient was on 1 liter oxygen mask, and came down to and improved. Was almost discharged within 10 days. This was the whole follow-up treatment of the patient. Thank you. Over to Dr. Samrat. Over to Samrat.
Thank you, Dr. Bimalanka. Now I will be requesting Dr. Chinmay sir to please share his case presentation. Over to Dr. Chinmay.
Hi, am I audible?
Yes, sir. Yes, sir.
Yeah. Very good evening to one and all. Many thanks to Gufic Biosciences for giving me this opportunity to present a series of cases in which we've used Immunocin alpha in the COVID-19 pandemic. Now, I am the consultant intensivist and head of critical care at KJ Somaya Medical College and Super Specialty Center. We have treated close to about 2,000, 2,500 patients in this COVID-19 pandemic. So we've developed quite a large base of patients which we are able to give these medicines to. In the initial stages of the pandemic, as I'm sure every one of you must have gone through, we were really helpless as to what needs to be done, what need not be done. There were a lot of haphazard therapies which were coming across, but it would be safe to say that over a period of time, when right now the cases are rising up again, but we are not worried as per the mortality rate going up because of the various therapies that are available now, including Thymosin alpha, which we've been using for a lot of patients. What I'll be doing is I've segregated the cases into mild, moderate, and severe. So we've had multiple cases at different stages of illness which come to us. So we are a special tertiary care center. So we have patients coming in from various centers with severe diseases also, which we try to manage at the best of our abilities. Starting with the first case, I'm starting with the mild cases first. So we had a 37-year-old male who had a medical previous history of pulmonary embolism and was started outside by his private practitioner with HCQ, doxycycline, and he was on acetrom for his pulmonary embolism. So when he arrived to us, he had come in with just mild breathlessness, was complaining of dyspnea, and his saturations were around 92, 93% on room air. Because he had a previous history of pulmonary embolism, he knew what the saturations are like when facing a pulmonary embolism. So he had read a lot of things about pulmonary embolism and COVID-19 relationships. So he was pretty scared at that point of time. And he was febrile at the time of arrival, was with a temperature of 100, with a pulse rate of 101. Pressures were maintained at all points of time. On arrival, his PaO2, FiO2. Now, the major concern that we are seeing in COVID-19 patients is how quickly they worsen into an ARDS-like picture. And it's a real terror what we face. That is why I'm focusing more on the PaO to FiO2 ratios over here, because hypoxia and the amount of FiO2 that the patient is receiving is also important. So as you can see over here, he had a PaO to FiO2 ratio of about 150. On arrival, his IL-6 was close to 13. We started the patient on the mild doses for Immunocin alpha, that is about 1.6 OD. And the rest of the medications, of course, we were continuing the patient on. By around the third day, his saturations had picked up. His PaO to FiO2 ratio was also close to 240. Rest of the parameters has also come fairly under control. The D dimer, which was not elevated in the initial stages, so that was another factor which was satisfying to him, that okay, he was aware that D dimer is the thing which will suggest pulmonary embolism in him. So he was happy that his D dimer levels are in fact 600 only. But on the third day or the fourth day, he had just mild dyspnea on exertion. He was treated very well because he had mild symptoms and was started on Immunocin alpha. Next, we had again a 34-year-old male with diabetes. He was on concurrent OHA for his sugar control as well. He came in with a saturation of 94, again falling into the mild symptoms category, but he had a he was tachycardic. He had a heart rate of about 122 with a temperature of 99. His PaO to FiO2 at the time of arrival was 170, which was falling still under, though it was still falling under the Gold's criteria for ARDS, but he was fairly stable at the saturations of 94. We considering him to be again a mildly symptomatic for COVID-19. We started him on the regular dose for Immunocin alpha. And over a period of the next 3 days, his saturations had improved. He was off oxygen and maintaining a PO2 FO2 of 300, which we were very happy with. In fact, even his IL-6 levels have come down to 6. And more importantly, he was asymptomatic. He would tell us that he's feeling much better and he was more active after the entire treatment course. Next, for mild symptoms, we had a 61-year-old male with hypertension and diabetic. He had received HCQ, azithromycin, ivermectin, and doxy. He was on Clexane, started outside itself, and came to us with just fever and cough. His saturation was barely 96, which was not really a cause of concern for us. So his additionally, his D dimer was also 553 when he came to us. So he was not really in the loop for starting him on low molecular weight heparin, but since he was already on it, we decided to continue with the medication, the low molecular weight heparin for him. He was started on the mild dose for Immunocin alpha as well, and in 5 days, his saturations picked up to 99 off oxygen with no symptoms, and the PaO to FiO2 ratio was still on the lower side. However, his CT chest showed a significant resolution from 5 by 25 to 4 by 25 on the CT severity score. Next, we had a 78-year-old female with hypertension and diabetic. She was on peptides and doxycycline along with HCQ and steroid, which was started already for her. She came in with just fever with a saturation of 97% on room air, and she had a PaO to FiO2 of 150, which rose up to 260 after the mild dosage for Immunocin alpha. Her fever, which was not there on arrival, she had no fever, but she had complaint of fever in the past. Her IL-6 levels had dropped down. She is having no symptoms at the end of 4 days of therapy with Immunocin alpha. Next, we come on to the moderate COVID cases. We had a 46-year-old female with no comorbidities. She was receiving antibiotics and LMWH and steroids. She just complained of cough with a saturation of 92% with oxygen. Her D dimers were 2000. Her PaO to FiO2 was 108. So for us, it was a pretty grim picture as far as ARDS was concerned. We started her on the 2 vials BD dose. So that was about 3.2 milligram twice a day. Which showed significant improvement just after the third day. We started her on remdesivir as well. Her IL-6 levels had come down from 19 to 10, and the LDH showed a significant reduction along with the CT severity score as well. Then we had a 62-year-old male with diabetes and hypertension. He was having fever and cough with a saturation of 92. His IL-6 levels at baseline were 58, though his PaO to FiO2 ratio was very low, about 81. For 3 days, he received, on the 4th day of Immunocin alpha, his symptoms had disappeared. Fever and cough was not there. His saturations had picked up to 98, though he was still requiring oxygen support. But his IL-6 levels, without giving any tocilizumab, had come down to 13. He was also kept on remdesivir along with the other rest of the medication, along with Immunocin alpha as well. His D-dimer showed a significant reduction from 4,150 to about 500. Similarly for ferritin, and the PaO to FiO2 ratio had jumped up almost to twice what it was on admission. Then we had a 79-year-old male with a history of Parkinson's, diabetes, and hypertension. He had no basic symptoms, but it was an old man presenting with generalized weakness. But the relatives had observed that, during the routine observation check of saturations, they had seen that his saturations were dropping down to 92% at home. So they decided to get him in with a temperature of 99. He was started on the 3.2 milligram BD dose of Immunocin alpha, giving us a saturation coming up to 98%, with him having significant improvement in his general conditions. Of course, his Parkinson's caused him to be slightly immobile, but rest of the parameters, the IL-6 levels and the PaO to FiO2 ratio, showed a significant improvement than what he was presenting to us with. Then we had a couple of severe COVID cases in which we gave Immunocin alpha. There was this female with hypertension and chronic kidney disease. She was with us for about 8 days. She came in with fever and history of fever and cough with a saturation of 85% at baseline, with a PaO to FiO2 ratio of 80, which was very low. Her IL-6 levels baseline were 39.6. We gave her Immunocin alpha, the 2 vials TDS dose, which is the recommended dose for severe cases. And at the end of the 7th day, on the 8th day, she was having a saturation of 96% with 4 liters of oxygen on nasal prongs. The symptoms that she was experiencing was just dyspnea on exertion. Her IL-6 levels had dropped down to 9.3, and the PaO to FiO2 had also jumped to 150. Another case we had was a 61-year-old female who had no comorbidities other than obesity. She came in with breathlessness and cough. Her baseline oxygen level was 85%. And she is on the 3rd day of Immunocin alpha right now. She's still admitted to the hospital. Her saturations have picked up to 92%. We had started her on remdesivir. She has received a single dose of tocilizumab as well. The IL-6 level has shown a significant drop from 20.6 to 0.1, and the PaO to FiO2 ratio has also increased for her from 60 to 95. In the subsequent days, we hope that her clinical condition and clinical status also improves, her oxygen requirement goes down, and we are able to send her back home hale and hearty. I think that's about the experience of, we've used it in multiple patients with a variety of signs and symptoms that we've had, and we've found good and promising results. We hope that this trend really continues, and this helps us to reduce the mortality of COVID-19. That's it from my side. I think, Dr. Samrat, over to you. Hello.
Yeah, Dr. Chinmay.
Yeah.
Yeah, thank you, Dr. Chinmay, for the wonderful presentation of so many case studies on Immunocin alpha. With this, I will be requesting our panelists comprising of Dr. Om Shivastov, Dr. Bimal Ranka, Dr. Chinmay, Dr. Adarsh Shetty, Dr. Rahul Bhaur, and also Dr. Navneet to please come across and answer the questions the panelist has put forwarded. I have already put down all the questions to Dr. Adarsh Shetty as well as to Dr. Navneet Wadhwa.
Thank you, Samrat. I'm very grateful to Dr. Om Shivastava, Dr. Ranka, and Dr. Chinmay for their valuable time in their busy schedule. And the talk was very engaging, refreshing, enthralling, and stimulating, and energetic and educational at the same time. So I'm getting a lot of questions. Yeah, I'm getting a lot of questions from my WhatsApp. So I'll be posing those questions to the panelist. The one question which I got from Dr. Rupesh Nayak, can it be given with tocilizumab? Dr. Ranka, I think, do you have any experience? Can this thymosin alpha can be given with tocilizumab?
Yeah, we have used in few patients whom we had given tocilizumab also.
Okay. Next question is from Dr. Saubhagya. What is the maximum number of days we can use Immunocin alpha for the treatment of COVID cases? This can be answered by Dr. Chinmay.
We have used it for a maximum of 7 days. We haven't used it for more than 7 days at any point of time. Even in severe cases, we have just used it for 7 days. In fact, we've even discontinued Immunocin alpha depending upon the clinical status of the patient. So the maximum that we have used is 7 days, not more than that.
Okay.
I would like to add up here actually, Dr. Vadva here. This is a very interesting perspective. I think it's a very, very vital question because, we are into the era of repurposed drug. The question, there are two aspects of it. One is the duration of the therapy, which becomes therapeutically effective at what point of time. I think it's very clear from the Indian experiences. Some of them we are translating into evidences as well review process. 3 days is the time when we can anticipate the result. That's I would like to address in two parts. One is the third day. Generally, we are seeing the responses. Number two element here is that how long it can be given. If yes, the concern here would be if the lymphocyte percentage ratio goes anything more than over and above 20%. I think Shivastov will agree on that front. But extending to the duration of it, how long? Till 18 months in other indications which have been approved, including by US FDA, like hepatitis B and other indications. 18 months, it has been found to be safe at a dose of 1.6 milligram. So I think it's the has to be in a direction of the fact that when do we anticipate response and when do we see the lymphocyte percentage improvement. That should be the basis for the duration of the therapy, because the evidences are rapidly evolving as a repurposed drug. Dr. Adarsh, we can take another question here.
Yeah, one second. So we are getting a lot of queries on the contraindications and adverse events. To answer that question, I will take that question. In terms of contraindication, this drug doesn't have any contraindication. Only contraindication is the problem with the skin. Means it's given subcutaneously. If there is some inflammation in the skin, that is the only contraindication. And coming to the adverse events, this drug doesn't have any major drug-drug interactions and no major adverse events. Only the injection site reactions is one of the adverse events which has been found.
To add to Dr. Adarsh Shetty, this drug has a feedback inhibition of its own. When the T lymphocyte counts are less, this drug improves the T lymphocyte count in the body. And when the T lymphocyte counts have reached the peak for the person, the drug does not act further. It does not overshoot itself. That is the reason it is safe. Number one. Number two, this is a body's endogenous product produced in the body from the thymus in early phases of life. Now we are just supplementing it externally, a body product to help to build a T cell immunity in the body. So keeping these two factors in mind, the amount of adverse events we expect are negligible. The only thing which we expect with this drug are some amount of erythematous rash, which is minor thing at the site of injection. That's it.
Dr. Om Shrivastava, I'd like to put a question to you. Looking into the data, what you showed in the initial part of the presentation, especially the convalescent patients, will it tell us that will thymosin alpha? We are seeing some cases of re-emergence of the infection as well, and the same individuals. So, will the patients have the deficiency of T cells after a due course of time, even once they have become RT-PCR negative? So will it be, can thymosin alpha be utilized in that scenario, looking into the entire spectrum of the mechanistic benefits across?
It's a good question. So will thymosin alpha be useful and efficient? So again, let me go back to the basics of immunology here. Simply, like I have mentioned earlier, simply having numerically normal T cells does not mean that your patient is safe. And that do remember that exhausted T cells may go through several generations of producing exhausted T cells until such time as the progeny becomes robust. So those of you who have handled HIV, you will know that when you do a measurement, that means when you do a CD4, which is the helper T cell, and compare it with the CD8, which is the suppressor cytotoxic T cells, that ratio has to be of a certain number. That ratio has to be, when it is more than 0.2, the chance that your patient is going to get a clinically significant event is less than about 5%, between 3 and 4%, less than 5% over the next about 3 months' time. When you've got a CD4 CD8 ratio of more than 0.2, just 0.2, 0.3 and above, that chance over the next 6 months' time, then the chance that your patient is going to get an event becomes much lesser. So it's not simply a matter of saying that T cells numerically are fine. And so what is going to be the duration of treatment? With COVID, I don't think that anybody knows. Right now, all the evidence that's available is on paper. It's very good on paper, but we would like to see the number of patients that have been discussed as case studies so far. I'd like to know in how many of these patients a T lymphocyte was enumerated. If they're not enumerated, then it's simply a matter of having the comfort of a clinical situation. Clinically, you are comfortable. That may be the case for immediate situations. Yes, I'm not denying that. But to say that this person's immunological status is sufficient for no problems in future, I think we need a sequential study of what these patients' T cell was like. Yeah. So uh, as of now, the answer to the question that Navneet is asking is that we don't know. As of now, we don't know, but hopefully in the next maybe 3 months time, 6 months time, we'll know more. But it is, assuming that an immunological response is going to be translating to what you think is appropriate, that's a grievous mistake. That's a big mistake and should be avoided.
Sir, in that context, I'd like to highlight one of the important perspective which has just been submitted. Exactly on your thoughts, sir, that how restoration of lymphocytopenia. In fact, this has been very evident in this case report which has been submitted. The CD4 plus CD8 ratio. I think that's also important. It's not just the factor with respect to just lymphocytopenia. I think we need to have our own evidences as well, which is rapidly emerging indeed at a quite rapid scenario.
Yeah. So again, I in one of the hospitals where I'm attached to, where
Yes,
we are using both plasma. We are using plasma regularly. It's probably the biggest hospital in the private setup where plasma has been used. We're also using tocilizumab. We are also using itolizumab. We are using, of course, remdesivir and favipiravir. But in that hospital, we are looking. I am asking for enumeration of T lymphocytes at day 0, which is, when the patient comes into ICU. Also on the wards, but certainly in the ICU. On day 15, when the patient is ready to be shifted, because most patients will be out of the ICU unless you've got a tracheostomy. Most patients should be out of the ICU at that time. And those patients who have gone home, which is now coming to the 3-month period. So the results, which are preliminary results at the end of 3 months, day 0, day 15, and day 90, they're very, very interesting. They're very interesting. I can't share them with you right now, but they're very interesting. So I think that, as I was saying, I don't think we know enough about the T cell response and the repertoire, but we are learning. We are learning, and we are learning every day. And that in that learning process, we will probably have more and more strategies. For instance, the question that was asked was, how much time are you going to use thymosin alpha? When do you see results? When do you see results? That's a very good question. I think that we don't know the answer to that. All right, the lymphocytes that you are measuring, how many of them are mature, immature? How many of them are, so you see, in the basics of immunology, It's not the CD4 count that is important. It is the CD45 count that is important, right? Because that's where your lymphocyte is going to be generated from. That is the baby lymphocyte, which will then mature into the CD4 that we are able to measure in the peripheral sphere. Unfortunately, CD45 is almost even after 10 years, it's almost a research tool. If you remember, Navneet would probably agree that if you remember 10 years ago, in one of the best known documented from articles from Nature, CD45 was meant to be the one tool. For some reason, it has never developed into the tool that is going to be most important for clinical outcomes. So I'll quickly stop my answer here. Again, look, I'm sorry about taking more time, but look, immunology, I'm very happy to talk about any subject on 1 minute's notice. You know, I'd be very, very keen to keep talking, but I'm going to stop here. I think that we are still learning about the immune responses of COVID, but there is a great deal that we can learn and translate into what is clinically important. Yes, Navneet, over to you.
Another question to Dr. Om Srivastava and the other panelists, Dr. Chinmay, Dr. Vimal Ranka, Dr. Rahul. You know, there is postulations for the safety factors of tocilizumab, what we are seeing. In fact, there have been some red flags coming on that. On the background therapy of thymosin alpha, if started appropriately in the earlier phase, considering the fact, you know, as sir also mentioned, you know, the lymphocyte practically that was minus means it was missing absent lymphocytes as well. So in considering the fact if thymosin alpha 1 is started appropriately in the early phase, will it delay or may allay the need for tocilizumab because on the fact that cytokine storm, and now we are even getting into dimension of bradykinin factors which are coming up very strongly in the literature. So will it prevent not just the usage of tocilizumab, but also the sequelae of tocilizumab, considering the so many papers which are there with respect to gastrointestinal perforations and so many other negative side effects of such a monoclonal antibodies. Over to the panelists and Dr. Om Srivastava for the comments on those and experiences as well.
I think that Dr. Om Srivastava should answer last. Why don't we invite Dr. Chinmay, Dr. Gokhale, and I will speak up last.
As Dr. Shivastov was mentioning, that it's like we are shooting in the dark at this point of time. We really, as he said, that clinically, yes, we are finding significantly improved results with respect to the use of tocilizumab, but we really need to know what is the state of the lymphocytes, whether the CD4 counts, what is happening with it when the patients are being started on Immunocin alpha. But what we have, if you consider clinically, then yes, what we have seen is that there is a reduction in the use of tocilizumab when we start patients on Immunocin alpha at the early stages. As in the initial phases of the pandemic, these mild cases which were there, which were not on any significantly useful medications, over a period of time of 10 days or 12 days in the hospital, they would land up in the ICU with severe breathlessness and gross ARDS like picture, which has definitely reduced. That is the reason why we are finding a reduction probably in the mortality rates in hospitals. That's why probably people are less scared of the disease, which should not ideally be the case. But definitely if started in mild to moderate cases, then yes, it is proving a big boon for us to prevent the use of tocilizumab.
Any other comment from the panelists, Dr. Vimal Ranka or Dr. on that regard?
Clinically, what we've seen is in the last 3 months, what we've seen is after we started using thymosin alpha in mild to moderate diseases, in mild to moderate cases of COVID, clinically, I've seen very few of them going in for, who requires really tocilizumab after starting with thymosin alpha. Initially, if you've given them tocilizumab, we may have started few patients on thymosin alpha, but gross majority of patients whom we started on thymosin alpha, very few of them required tocilizumab. I mean, the recovery rate was quite good in those patients, and the chance of cytokine storm also very less in such patients.
Yeah, so the points made by both Dr. Godbole and Dr. Ranka are very appropriate. I think that if you look at any therapy, if you even see the last ICMR trial on plasma, any therapy that is going to be changing the immune response needs to be started at an earlier stage rather than when the patient becomes moderately sick. And definitely, in spite of all that we all believed and hoped that patients who are the sickest are going to benefit from all of this therapy, you can't wait, because the immune trigger that is going to be uncontrolled after that comes at a stage which is probably in the early part of the disease. So if you say that, yes, I used plasma or I used thymosin alpha on the fifth day, a lot of naysayers and a lot of people who are skeptics, they are going to say, but your patient would have probably recovered on its own. Now, the problem with that kind of an approach is you don't know. You don't know if you had not used thymosin alpha or any of the other agents that we are talking about. If you had not used them, what would have been the outcome? Are you prepared for the about 3% or 4% or even 15% mortality in some ICUs? Are you prepared to take that chance? The point is no. My answer is no. That's clear. I'm absolutely certain that if I have a risk profile, and I'm sure that a lot of my colleagues are using that profiling. If you think there is a profile in a patient where he is going to go into a complication, I can't see the point of waiting till a complication is beginning to occur. I'm going to start it at a time where I'm on top of the complication even before it starts. So I think that there is a role for thymosin alpha. If I had to put a day, I think it would be around the fifth day that your patient comes to your ICU. That would be the time where I would use it. Of course, this is my own understanding, perception of people who go into complications. I could be wrong. I'm ready to be corrected if there is evidence otherwise. But as a clinician, because I don't read papers, I don't read numbers, I treat patients. I'm sure all of us do. But as a clinician, if I were to make a call, it would be around the fifth day of starting any modulatory therapy, and not later than that. I'm not going to wait for a complication to occur. So if the role of tocilizumab or itolizumab becomes redundant, it can't get redundant, but it becomes much lesser than what it would have been otherwise, then so be it. So be it, because I'm going to use this before the cytokine storm starts.
So perhaps the reason why this question would have been there is because there are a lot of confounding variables. Ideally, we need a placebo-controlled trials to demonstrate and compare apple to apple and oranges to oranges. But the current scenario and the disease per se does not permit that to be so easy in that regard. Sir, another question I like to take up, which is coming up repeatedly, is the utilization of thymosin alpha 1 in liver disease, renal impairment. There is a clear-cut documentation that even in decompensated liver disease, this is with respect to the overall usage of thymosin alpha 1, irrespective of COVID, that even in decompensated liver disease, it has been found to be safe. And in fact, it has been utilized well in patients on and who have been on hemodialysis as well. In fact, there is a report of course, this is the utilization in a non-COVID scenario, which otherwise becomes as a repurposed definition becomes to a certain extent similar. That uh, it has been documented well to increase the number of CD4 and the CD8 plus cells in a cytomegalovirus infection as well. And on the premise that possibly the I would say the T cells response is already diminished in patient with hemodialysis. So there may be a relatively much better response in that patients because of the deficiency of T cells. Comments from the other panelists on that. Any experiences as well on that?
Yeah. So again, why isn't Dr. Rahul Bahut commenting? Rahul, where are you?
Yes, sir, I'm here. I'll comment on this. Using thymosin alpha, I found in my experience early in the phase of the disease helps. Because if we see the pathophysiology of the disease, as Dr. Umshwasa rightly pointed out, when the cytokine storm happened, one of the basic pathologies is that the T cell counts decrease, the lymphocyte count decreases, the functionality decreases. Where does my thymosin alpha act logically? It acts by replenishing the T lymphocyte and creating a functional T lymphocyte subset. So instead of waiting for my patient to come to the ICU, I rather start to alpha thymosin as soon as the report comes positive for COVID. And this is the safety standard which I have adopted in my practice. And to prevent, rather than going to the ICU, facing the complication, and then trying to bring in a molecule, I use it quite early in the phase of the disease. And I have seen fantastic results with it, with my patients not going into cytokine storm at all. And like Dr. Omshiwas also said, it is very important to do T lymphocyte counts to document your improvement. Mind you, doing these counts add a cost to the patient, but they do provide satisfaction at the end of the day to the patient. When they see their cell counts, this is the best thing what you can offer a patient, a smile on his face. And that is what I would place a molecule even before the 5th day of the therapy. As soon as it is detected, we should start with it. This is my personal opinion on it. Sir, you can modify it.
So I think that the
And as
only thing
compared to the chronic renal failure, that yes, sir.
no, so the only
There's
thing
a
to
huge
modify,
trial going
Rahul,
on.
I'll quickly make just one quick point, just one
Yes,
quick
sir.
point, Rahul. The only thing to
Yes, yes,
modify
sir.
that the cost of lymphocyte enumeration is much, much less than having
Yes,
a patient in ICU where you don't know where to go from one point to another. So yeah,
yes,
it's
sir.
it's it's, it's a very
Yes,
small
sir.
price to pay.
Right, sir.
Very
And
rightly
sir,
put, Doctor.
to add to the safety in renal profile, there's a huge trial going out in the US. We'll get the results by the month of January for prophylactic use of thymosin alpha in chronic renal patients to prevent COVID infection. This is a huge database trial which we are looking forward to, and this will help us to have more confidence on the molecule.
Sir, another question: can it be used in diabetics on OHA? Straightforward.
Mm, yes, we have used
Yes,
it
it
in
can.
diabetics and OHA, but we have not seen any much drastic contraindications to their use. And as you said, we expect the clinical symptoms to increase by come to back to normalcy. The table turns by day 4 of the injection. So if you are expecting that in one day you will get a drastic response, the answer is no. You have to wait for
But
a particular period,
the
3 to 4 days for the drug
the
to build
biggest
up,
problem that
and the
comes in
response
that
to build up.
situation, the biggest problem that comes in that situation
Yes,
is the concomitant use of steroids, which I'm sure everybody is using because steroids
yes,
are known, they are
yes.
shown to be able to prevent complications, particularly if you're using dexamethasone. The Oxford
Mm,
trial spoke about
mm,
4 milligrams of dexamethasone twice a day. If you're using dexamethasone, yes, then
right,
the sugar increase is more than 30%, 30 to 40%, somewhere there. And that is also transient. So patients who are in
right,
ICU may require therapy, additional therapy for a short period of time, but that settles down. I think after discharge, it probably
right,
takes about 3, maybe 4 weeks time to settle down, but it comes back to being normal. So I don't think that's something which is a huge
right.
problem. The only thing that I wonder whether there is a role, especially when we use things like tocilizumab and itolizumab, we good about, again, 30 to 40% patients will go into septicemia, and sometimes that is
Mm,
prolonged. That's also fatal
mm,
if you leave it, if your infection control practices in your ICU are bad. That can be fatal
mm,
as well in about 10-12% patients. So I wonder if there is a role that when you're using an immunomodulator for a prolonged period, 7 days, 8 days, 10 days, I wonder if there's a role for
mm,
some kind
mm.
of a prophylactic antibiotic, and whether that will help in uh, streamlining outcomes, whether that is likely to happen. I don't know what are the comments of other people. Please opine.
Yes. So, the basic problem which I feel these people obviously undertake, they make this immunomodulator as a primary mainstem of the therapy and forget that this is the add-on therapy. Is supposed to adjuvant the primary therapy which we are giving to the patient. I think so that is where we lack in everything. And there are studies across the place where immunothymosin alpha has been shown to be beneficial in sepsis. There are a number of trials published where it has shown positive effect in retrieving the patient from sepsis. But at my personal experience, till your patient is in does not go into a multi-organ failure earlier instituted, the better is the response. But like Dr. Umshwat also said, in later phases when the chain reaction starts, the response is dubious. It cannot be even seen in some patients. So there's a bit gray line here, and we will learn from our experience, which is growing.
Very well. Sir, one interesting question that
So
is there any data with respect to the usage in bacterial sepsis? I think that has been highlighted well from a mechanistic standpoint.
I think
comments
Tamir,
on that.
I'd like to hear the opinion of the remaining panelists. Let's ask.
Yeah.
So previously, before the COVID-19, we have not used Immunocin alpha before that. Yes, there are paper trials which are published for the use of Immunocin alpha in sepsis as well. But previously, we were not using it. When the pandemic hit us, multiple drugs, multiple therapies that we started experimenting with, essentially, we started observing that yes, there are certain drugs which are giving us more benefit as compared to the rest of the stuff which were really not of any use. So we don't have any experience of dealing with Immunocin alpha in sepsis per se, but there are papers published, as Dr. Shivastov sir in his presentation rightly pointed out. As regards to what the experience for sorry, hello, can you hear me?
Sir.
Yes, you're audible.
Yeah. So we have not used it in sepsis per se, but definitely and additionally, as Dr. Rahul Bhaut sir was pointing out, it is important to know that this is an adjuvant therapy and not just the mainstream of therapy. So there are other medicines that we do use according to the clinical status of the patient, and baseline antibiotics, the steroids, low molecular weight heparins should also be continued as the mainstream therapy, and this will act just as an adjuvant to them.
Yeah, we have got one more question from Dr. Abhishek Jain and Dr. Wadhwa. Is that neutrophil to lymphocyte ratio helpful for any initiation of thymosin? Or is there any dose adjustment required in these type of cases? Since this is neutrophil to lymphocyte ratio, which is one of the prognostic marker, I think the 3.13 is one of the cutoff point. So I'll pose this question to Dr. Ranka. So neutrophil to lymphocyte ratio. Over to you, Dr. Ranka.
So can you just repeat? The sound there's some problem with the sound.
Neutrophil to lymphocyte ratio. Is it helpful for the initiation of thymosin alpha? Since neutrophil to lymphocyte ratio is one of the prognostic marker.
Yeah, I mean, there are a lot of studies we've seen that the lymphocyte depletion has something to do with the prognosis in COVID patients. So we do see there is a lot of lymphocytopenia in COVID patients. And whenever the set of patients that we use Thymosin alpha, we monitor the lymphocytopenia also. And patients showed gradual improvement in the lymphocytopenia. And the majority of patients, even whom we not use Thymosin alpha, we've seen that there is gradual reduction or there is a lot of lymphocytopenia or there's a of the lymphocytopenia. The overall prognosis seems to be not very good.
So, Shivastava, do you have any comment on this?
So Dr. Ranka is right. I think that once you have shown that even if you were to take lymphopenia as an independent marker, of course, lymphocytes neutrophil ratio is important, but even if you were to take lymphopenia as an independent marker, that's a very good indication to start thymosin alpha in the earlier stage. But look, this is the point I'm making repeatedly. Thymosin alpha needs to be started at an earlier stage after you have calculated the risk of this person going into a complication. Your skill, my skill as a clinician is being able to identify, as a clinician at the bedside, to be able to identify the one patient who is going to go into a complication. Once you've identified that, then you have to start therapy as aggressively at an earlier stage. By the time you come to the 5th day, 6th day, if your therapy for the next 10 days is not ready, then you need to be ready for complication. This is as simple as that. It's very, very straightforward. There will be ratios that will come and go, and there will be more and more evidence of newer ratios. But you need to, I come to the point I have made earlier, please come to a risk assessment by the time your patient is on this 4th day or 5th day, and prepare for your therapy at that time itself, no longer than 5-6 days of the time you've met your patient.
So just addressing a very common question which is coming consistently, I like to take it up. The dosage across the different spectrum. For example, in prophylaxis, what has been postulated is 1.6 subcutaneously weekly, twice for about 1 month, and then subsequently, and in mild symptoms, 1.6 milligram one vial, that is subcutaneous OD for about 1 week, and as the severity relates to the dosage modulation as well, with 2 vials BID in moderate, and then 2 vials PID in severe symptoms. Uh, just a last question to the panelists in that regard. Will it, this is the same implications it has clinically as well, in your experience, with respect to the cases?
Yes, it does. In my experience, yes, it does.
It does.
Yes, certainly.
Okay, so thank you, the panelists. I thank you all for the beautiful panel discussion that has gone on with the question answer. As we have already exceeded more than 9 minutes of our scheduled time, so we will be starting up with the closing remarks. So this webinar session was sponsored in technical collaboration of Gufic Biosciences Limited. For any further queries regarding Immunocin Alpha, the brand of Thymosin Alpha, you can of course write to our info@guficbio.com, and our medical team will get back to you for any further details if anyone wants to know about the drug. This webinar session was sponsored by Immunocin Alpha, modulates immunity perfectly, Thymosin Alpha 1.6 milligram. And with this, I will put forward the session to our Assistant Vice President, Mr. Shekhar Ale, for his closing remarks. Over to you, Mr. Shekhar Ale.
Yeah, thank you, Shamrat. Good evening to all. Regards from Gufic Biosciences Critical Division, it's our great pleasure to thank all delegates from India and Nepal for joining with us. We'd like to thank sincerely to those delegates who attended our last webinar also on August 28th on the role of Thymosin Alpha, the perfect immunomodulator in management of COVID-19 patients. We are thankful to Honorable Speaker Dr. Om Shivastov, who is one of the leading COVID-19 fighter at Mumbai and important member of COVID-19 Management Task Force of Government of Maharashtra. We thank him for sharing his valuable time and sharing his knowledge and experience for the benefit of all delegates. We are thankful to Dr. Bimal Ranka from Ahmedabad and Dr. Chinmay Gadbole from Mumbai for giving their valuable time, for sharing their practical experience through case presentation for the benefit of all delegates. We are thankful to Dr. Rahul, Dr. Navneet, Dr. Shetty for giving your valuable time to make the session interactive. Gufic Biosciences has taken the initiative to update the medical fraternity regarding the vast role of Thymosin Alpha in various stages of COVID-19 through webinar series. Our next webinar is scheduled in mid-October. Very soon we'll inform you the exact date and time of webinar 3 on different role of Thymosin Alpha. Regarding the molecule, if you have any queries, as told by Samrat, please mail to the given mail ID as info@guficbio.com, or please inform to our field staffs. The response of Immunocin Alpha is very satisfactory, very encouraging. Wherever we have launched, in many cities, we could not launch due to the shortage of stock. Now we have manufactured in sufficient quantity and airlifted to all locations for the benefit of the needy patients. So tomorrow is World Sepsis Day. On behalf of Gufic, we take the opportunity to convey our regards and salute to all attending doctors for your fight for the mankind. Lastly, once again, thanks to all for joining with us and passing the benefits of Gufic's world-class quality products to millions of patients. Very soon we'll meet again in webinar 3 in mid-August. Good night to all.
Thank you.
Thanks.
Thank you and good night to all.